Welcome, everyone. Thank you for joining today's webinar. I hope you're excited. We have very good things in store for everyone. So I hope you're excited for the session. I'm Gloria from inSupply Health, and I will be the moderator for today's webinar. Come ready to learn. Wishing you all the best. We have amazing speakers lined up for you for today. And we hope that the learnings from today will be very impactful to your practice as a healthcare provider. So we have 3 speakers. We have 2 from Shujaaz, and we have 1 from the Ministry of Health. So we have Bridget. If you've interacted with the poster, Bridget is the managing director of Shujaaz Inc. and a passionate believer in the power of story to drive social change. And this passion has led her to work with Shujaaz Inc. in Kenya since 2019, and she leads the creative and production teams overseeing the design of multiple behavior change campaigns and winning 2 international Emmy Awards. Before moving to Kenya in 2006, Bridget worked at the BBC in London, specializing in youth television drama. And then we'll also have Paul Gitonga, who is a manager in Shujaaz Knowledge and Learning team. And he ensures all the data generated internally at Shujaaz and by external research partners is translated into insights that shape Shujaaz Inc. Then we have Naini, a very amazing lady who is championing youth initiatives in Nairobi County, and she will be taking us through what does that look like, what would a young person consider comfortable when they go to seek services in a pharmacy. So I hope you're excited and we have good quorum to start. So this webinar is done in partnerships with the associations, the Pharmaceutical Society of Kenya, the Kenya Pharmaceutical Association too, and we have Nairobi City County, where one of our main presenters is from. Then we have Shujaaz Inc. and inSupply Health. And we are going to focus on youth, reimagining healthcare for young people in the pharmacy. Bridget, if we could go to the next slide. So you will be muted during this entire session to ensure that we have a good quorum and we are able to have the session smoothly without any distractions. Please feel free to ask any questions you may have, and these questions will be addressed by our presenters. Please, we are recording the session and you will be able to go back and pick up the learnings and the exciting things you'll be taught today. And you can find this recording at the inSupply Health's YouTube page. Please also remember these webinar is CPD accredited. So also please remember to subscribe on the PPB portal to get your CPD points. I know this is something you're aware of, so please ensure you subscribe to the same before time is up. What will we be learning today? We have amazing things planned. By the end of these sessions, you'll be able to understand what are your clients' rights. Youth are legally entitled to sexual reproductive health services, no judgment allowed. So we are going to talk about that. We are going to talk about our own attitude and how we fix that, how provider bias is the number one barrier to youth using pharmacies. So how can we improve that? Then how can you make your pharmacy youth friendly? Of course, private, because young people love privacy, and how can they get accessible and non-judgmental services? And of course, we are going to talk about norms and not just facts and no, and for us to know when to refer if it's a case that you are not able to handle. And then we are, of course, going to learn about correcting the myths, misconceptions, that contraception isn't permanent per se, those who think condoms aren't enough, and all that. So it will be a very learning filled session, and I hope you are excited. And we have good quorum. We can start. We are going to start with one of our partners' presentation, take us through youth-friendly services, what that looks like through the journey and everything they have done. Feel free to type your questions for them to answer. Welcome, Bridget.
Thank you, Gloria, and good evening, everyone. My name is Bridget Deacon. I'm Managing Director at Shujaaz Inc, and I'm here with my colleague who will introduce himself, and then we'll turn our videos off just to save on bandwidth once you know who is speaking.
Yeah, good evening, everyone. This is Paul. Really happy to be presenting and meeting you all. Thank you.
Great. Well, just a big thank you to inSupply for this, the invitation to join you all this evening. Both Paul and I will be sharing some insights from our work with young people and around their sexual and reproductive health that we hope will be interesting, informative, and relevant to your work. So for those of you who don't know us, Shujaaz Inc is a youth-powered behaviour change organisation. We believe that it's young people who have the power to transform our society for the better. But as we all know, there are many barriers that stand in their way. And so our mission as Shujaaz Inc is to break down these barriers. Now, they may be internal barriers, the fear that we have about stepping outside of accepted norms. They may be societal barriers or even structural. But we break these down so that young people can take control of their futures. Now, we do this as Shujaaz Inc by being in a constant conversation with young people across Kenya on multiple different platforms. And we have these conversations to really understand them, to understand their lives, the challenges they face, their hopes, their dreams. And then we work with them, we co-create with them the solutions, telling their stories, their life hacks, their hopes, the things that they're doing in their life to take a bit of control. We tell those stories on TV and print, online, and in their communities through events and through peer-led youth activation. Now, we're a media organisation, so we've made you a video to give you a sense of who we are before we go on to share some insights with you.
We make media for young people, by young people, and with young people.
Na ni kwamba like na zile story plus ni entertaining, educative, ni poa tu.
Inajaribu kujenga mayouths wajaribu kusolve problem zao kwa jamii kama kuacha pombe, mental health, pregnancies. Inajaribu kuelezea nini wanafaa kufanya wakipatwa na shida kama hizo.
Shujaaz is the largest youth media brand in East Africa.
Thank you. So hopefully that gives you a little bit of an idea of who we are and what we do. But I think what's really important is that everything we do at Shujaaz is rooted in data. Our behavior change campaigns are informed by data and insights, those conversations I mentioned earlier. And also we're constantly measuring and learning what is the impact of engaging with this media, with these campaigns on key behavioral incomes and outcomes. And that's what we want to share with you today. So Paul's going to share with you a little bit about what we know about young people and their reproductive health, and also how do we know if this is having a true impact. Over to you, Paul. Paul, you're on mute, just in case you aren't aware of that.
Sorry. So thanks, Bridget. Now, before I start, you might notice that we haven't called this slide family planning or SRH. And the main reason is this is not how young people think. They have relationships which can be complex, which can be messy, and meaningful, painful, and they have sex for fun and for connection and sometimes for more complex reasons. And if you're to really meet young people's needs, we need to start there. And what we also know is that this generation of young people has big dreams. They want to finish school, they want to run their own businesses, they want to choose when or even if to have children or families of their own. And for all of us, making these dreams happen can often depend on one thing: how you take control of your relationships and your sex life. Or just the way we say, your sexual and reproductive health. So here's one focus group participant. So here's how one focus group participant put it. My cousin was 14 when she had her first child. My mom was 12. I thought, no, I refuse to let my future be like that. That's what sexual and reproductive health is about, whether you are in control of the future you want or not. And so here's the good news. Over the years, we've seen an increase in 15 to 24-year-olds doing exactly that. Almost 9 in 10 young sexually active Kenyans now say that they have tried at least one method of modern contraceptives. These are condoms, implants, injections, or even daily pills. However, the use of these modern contraceptives is not yet consistent, and that is that red line below. While 85% have tried a form of contraception, only 72% currently say that they have used one the last time they had sex. And as a result, we're seeing too many young girls getting children before they choose or plan to. So awareness is high. More than 9 in 10 can name one or more types of contraception. This is without a prompt. And 80% say that they know where to find them. So if you think about what are the barriers that are holding young people back from using contraception consistently and building the future that they want. Now, before I go on, I just want to ask you all just one simple question. You can please note down your answer, even if it's in your heart. What do you think is likely to have the biggest impact on a girl's consistent use of contraception? Between these three options: income, education level, or friends. Now, no one will know your answer, so please hold on to one answer. Okay. Now let's mark that homework. So the biggest impact on modern contraceptive use is if you think your friends are using modern contraception, like what's perceived as normal among friends. Now, this is something that's very relevant and we need to unpack today. So our own research shows that if a girl believes that all or most of her friends use modern contraception, then it significantly increases the likelihood that she'll use contraception the next time she has sex. Like when we believe something is normal, like people like me, my friends do a certain kind of behavior, then we feel that it is okay, even encouraged to do the same. But by the same token, our data shows that if you're a teenage girl in Kenya and you believe that people like you and your friends don't use contraception, or that even that they shouldn't use contraception, it significantly reduces the likelihood you'll feel comfortable using contraception the next time you have sex. So there remains persistent, complex layers of negative and social, cultural norms and myths and misconceptions surrounding the use of contraception. Again, after 14 years of Shujaaz, we're convinced that these negative norms are some of the biggest barriers preventing young people, and especially particularly girls, from taking control of their futures. But there's a silver lining. It proves that we can break those barriers down, like we have identified the problem. In fact, when you don't have to be rich or have a degree, and if you can change the story about what's normal when it comes to contraception, you can find the motivation and the agency to take control of your future, regardless of who you are and where you are from. And so this is our big recommendation for how we can support young people to take control of their sexual reproductive health. We need to change the story amongst a whole generation of young people about what is normal, what is okay, if we really want to see real change. The other insights we're going to look at is about the importance of conversations as well as innovation in distribution. Okay, so as we have seen, changing the story about how young people think and speak about their sexual reproductive health is really critical, and it's a focus for us at Shujaaz. The power of storytelling and social behavior change communication is that we know we can change that story. But to do this, we need to really understand how young people not only think, but even the words that they use to talk about sexual reproductive health. Have a read of this quote from another focus group. Okay. I'm sure some of you notice something surprising. Have a look at it again. Because here's the thing. In Kenya, it is not uncommon to find a young person saying that they don't use contraceptives, and in the next breath, talk about their preferred type of condom. And that's for one simple reason. Words do matter. For young people, this is how they think about it. So for them, protection refers to the easy to access traditional methods that we all know, the safe days, withdrawals, P2. And for them, it allows you to protect yourself from sexually transmitted infections or intended pregnancies. But crucially, nothing about protection is permanent. It gives you the flexibility to have kids straight away if you meet the right person or the right kind of, or if you feel you're ready, but it doesn't change anything about you, either your identity or even how you define yourself. You can use protection for some young people and still think of yourself as a virgin. And that's really important for them. Whereas contraception, for young people, they refer to this contraception as the long-acting methods. Here we're talking about the daily pills, implants, injectables, which often require someone to go to a clinic. Using the contraception for young people is viewed as a much more permanent change associated with adulthood and people who are actively planning a family. At Shujaaz, we don't even use the word FPO, family planning, because again, there's that connotation. Add to this equation the prevailing myths about how using one noun might prevent you from having a child later. And so to use contraception, therefore, requires you to make a much bigger decision, and more importantly, it requires a big identity shift. And so what's our takeaway? Whether you're asking questions or sharing information, if you're working to support young people to choose the contraceptive method that's right for them, it's very important that you use the right words because they signify identities. So again, I will stress that when it comes to contraception, the conversations really matter. Conversations that we have with our friends, people that we trust, about taboos, sharing experiences, asking questions that maybe we feel very, again, nervous about. And again, this make a very big difference. except there's a huge problem where too many young people don't have access to safe spaces, both online, both offline, to have those judgment-free conversations. And again, quoting our research and even external evidence, we have seen that creating these safe spaces for young people to meet, have taboo-busting conversations with peers outside their existing networks is something that is incredibly powerful. And so over the past few years, we've been creating youth-friendly chatbots that can emulate the power of these one-to-one conversations in real time, so quick, and help young people connect them to reliable information and safe spaces to find answers to their questions. These chatbots have been co-created with these young people, but also with professionals, including Kenyatta National Hospital and a network of service providers. And so this is our first chatbot. Can you play the video, please?
No, yo, like in the cut, season. When you don't get into the 90 bed, Chinese got the dreads, teaching Ghana what's next. Like so to make it, I think that I'm the best. But when it comes to that, I'm not alone, starting to.
Okay, that was the first chatbot, Semana Me, Sheng Speaking, judgment-free, WhatsApp chatbot, where you can get friendly advice and reassurance if you're a young person before you get referral to a professional service provider that suits your needs. Additionally, we have 2 new chatbots based on Shujaaz's most popular characters. I don't know if you know them. Definitely, some of you do know them. So these chatbots provide safe spaces for conversations about any taboo topics, and they are modeled after our well-known fictional characters. So this is DJB and Maria Kim from the Shujaaz story world, and these are characters where young people have grown to trust and confide in as these relatable young people who are just like them, going through the challenges just like they are. And again, this trust has been built over 15 years. And so at a glance, for Semana Me, within the past 1 year that actually it has been active, you can see that we have close to 11,500 unique users in almost all corners of the countries of Kenya, and we have 50% actually returning for a second session, but importantly, we have 58% getting referred to a service provider. And looking at some feedback about Semana Me, so we did run some sessions with some of the some focus group sessions with some Semana Me users, and you can see from the messages that they shared with us is that the value that they see in being able to talk openly and freely about sex and relationships in a safe space. But interestingly, they don't always want to be referred to a provider. They just need to sort their heads out, get some advice, and definitely when they need to take action or when they feel that it's time to take action and they're ready to do that, that will happen in due course. Similarly, we also wanted to just showcase a few messages that we do get on the chatbots. And so we can see everything from very vulnerable issues around abuse to even down below requests for information about contraception. So it's clear there's a big need for professional counseling and for services. And especially important to bridge that gap between these conversations and the places where young people can access the services and products that they desperately need. Hence why we are collaborating with inSupply on this. So what does this action look like? And so as I started, we're all aware that young people still face some big barriers, especially during that last moment, that last mile when they've decided, okay, I had these doubts now from this conversation, we've spoken and I've decided now it's time to take control of your reproductive health. And sometimes this is at the point where in a time of crisis. And to bridge that last mile, that moment is what Shujaaz is exploring with inSupply Health. Again, we've known over the years that young people are nervous about being seen publicly picking up condoms or about feeling judged when they go to a sexual health clinic. Again, some of them also experience some structural barriers when they'd like to trial something like an injectable contraceptive, but again, such things remain inaccessible because either mostly due to supply chain challenges or not knowing exactly where to get one. So over the years, Shujaaz has built partnerships with youth-friendly organizations who we refer our members to so that they can get services they need through discrete delivery options, and now even pharmacies. Okay, over to you, Bridget.
Thank you, Katonga. So I hope all of that's been helpful about the power of the stories that we tell ourselves and we tell each other about the type of conversations that young people need to have, and now how we connect them to the services, to the products that they need. So as Katonga mentioned, we've built partnerships with youth-friendly organisations who we can refer our audience to through the chatbots and also through community outreach so that they can get these services they need through discrete delivery options. These chatbots have been an excellent way to connect young people directly to these last mile service providers, and we're continually learning from the data which these services work best for young people to help us iterate and design the most effective user-centric solutions. So we'd really love to keep this conversation going with those who are interested in being part of this network. We know that pharmacies are the preferred place for the majority of young people to go and get their sexual health services and information. They trust pharmacists. They're able to walk in and no one knows why they're going into it. And so we think this partnership, this collaboration is really key so that we can support more and more young people to take control of their reproductive health and also to take control of their futures. So thank you very much. Back to Gloria.
Thank you, Bridget. Such an amazing presentation. I hope all of you are excited about things that we are learning about the young people and what their needs are. Our next speaker is Naini. She will introduce herself briefly and take you through the next session. Welcome, Naini.
Thank you, Gloria. Glad to be here. My name is Elizabeth Naini. I work with and for Nairobi City County government as the head of adolescent and young people. And so I'm glad to be part of this conversation, just to be able to discuss how we are going to reach out to adolescent and young people in terms of accessing services in our facilities. And in this case, I am very cognizant that we are talking about the pharmacies, which our young people really prefer getting services from. So thank you very much. Let's continue, Gloria. So I'll take you through just when you're talking about adolescent and youth-friendly services, what exactly are we talking about? And it is also a way of, self-examining ourselves, those ones of us who are providing services, whether they meet the criterion of being adolescent and youth-friendly. And if not, then we can pick a thing to just go and improve so that at least our young people will be able to access our services. So to start us off, I think it is important, again, just to remind ourselves, when we are talking about an adolescent and young person, who exactly are we referring to? So when we talk about an adolescent, I think it is any young person between the ages of 10 to 19. That is according to WHO. And a child, and especially in our constitution, is anyone below 18 years old. A teenager starts from 13 to 19 years, while a young person now encompasses both the adolescent and going all the way to 24 years. So a young person or young people, the phrase is used interchangeably, is anyone between 10 to 24 years old. And this is also a definition given by WHO. So youth, for example, depending on where you are, if you're in Kenya, constitution will define a youth between 18 to 34 years, while WHO, you're talking about 15 to 24 years being a youth. So what is an adolescent and youth-friendly service that you're going to discuss? Basically, we are talking about services that are delivered in ways that are very responsive to the needs of young people, looking into their vulnerabilities and desires of the adolescents. And we all know that young people, or adolescents and young people, have various vulnerabilities. One, of course, is the physical vulnerability. These young people are going through a growth span, if I might say, that brings a lot of concern. There's also emotional vulnerability that comes with the growth span. They're trying to transition, they don't understand themselves, and so many other, including the socio-economical vulnerability. And so when you're tailoring their service, we always need to remember especially the economic vulnerability. They might not be in a position to afford the services in case we have to attach a cost into those services. Next. So let's again look at the document or the policy frameworks that guide us in the provision of adolescent and youth-friendly services, especially here in Kenya. And when you look at the legal documents, because this is very key, many people get lost between, providing service to a minor and which frameworks support them. So the most important one is the Constitution of Kenya. And when you look at Article 43, 1, every person has the right to the highest attainable standard of health, including reproductive health. So we should always remember that every person includes an adolescent. It also includes a child, but for our case here, we are talking about adolescent and young people. And so the Constitution, provide a basis to a legal framework for provision of these services. We have other documents also that support the provision of AYFS, and one of the documents is the National Adolescent Sexual Reproductive Health Policy of 2015. I know this one is being revised. I think it should have actually been released, only that it hasn't been launched, the 25 version. And in this document, looking at the implementation framework as well, it's actually stated that adolescents have the right to access sexual reproductive health. And when you talk about sexual reproductive health, information is also one of the key components, including also services. So, but it also states that they should be meaningfully involved in SRHR program, not just providing the service, but also getting the ideas on how do they want these services being provided to them. We have other documents like the National Reproductive Health Policy of 2022. It also mentions that we need adolescents and youth should access SRHR information and services. And then we have the National Guideline for Provision of Adolescent and Youth-Friendly Services, which actually guides us in whatever that, especially what I'm going to share today. It defines what is an adolescent and young person friendly service, the package, what services do we are we entitled to provide in the package for AYFS. Next, Gloria.
Bridget. Okay.
So it is also very important to understand the health risks and challenges facing the adolescents. This is a background of it will act as a background on the information on the services that you are going to provide to them. And when you look at the challenges that young people are facing in this country, there's a common phrase that the government has put it. It's talking about the triple threat. Triple threat basically is and high teen pregnancies among the adolescents, teenage pregnancies, sexually transmitted infection, high, especially the new HIV infections, and increase a number of gender-based violence among the young people. So teen pregnancy, new HIV infections being high in young people, and gender-based violence. Those are the main one. But when you look at critically and dissect the triple threats, you can now say, if a young person gets an intended pregnancy, they will end up getting an abortion. And when we are not talking about safe abortion here. If they are not ready to carry a pregnancy, they will go for the back streets and procure an abortion, which might complicate. When you're talking about gender-based violence, there are other tributaries to gender-based violence, and one is the mental health issues. And so we have a lot of depression that is tied to use of substance and drug abuse. All those issues that are, affecting the young people in the country. So, and when you're looking at a young person, when you want to see how is their health-seeking behaviors, we all know that for a young person, especially in terms of seeking SRHR services, anything to do with sexual reproductive health, they become very shy, and most of the time they tend to mask their SRHR problem, so that if they present themselves to a facility or to a pharmacy, for example, and the pharmacist or the healthcare provider does not know how to interrogate in a very friendly way, adolescent-friendly way, then they might miss out the point. Their answers is usually no as the first, or maybe yes, as they gauge how the provider is going to engage with them. They also tend to come to a facility late hours, when no one is watching. And probably for those ones who are in higher learning institution, probably that is the only time they have to present themselves in a facility. So they come late hours or very early in the morning, or if they're not comfortable to seek services within where they stay, they will rather travel a little bit to go and seek services further from where they live. They also tend to depend so much on their peers, information from their peers. They trust their peers. And internet is also Mr. Google. Before they present themselves to a chemist, for example, they have already asked Mr. Google what, and self-diagnosis and even medication. Then when things don't work is when they present themselves to a health facility. So it's always good to put this at the back of our mind, that it's not very straightforward that a young person will just come and ask for a contraceptive. They have to beat around the bush, so that it depends with the techniques of the healthcare provider in questioning or asking, engaging the young person so that they get this information from them. Thank you. Let's proceed. So we have barriers. Why? And even the presenter that was before me mentioned that young people, they have barriers as to why they're not coming to seek for services in a facility. Could be a private facility, could be a public facility, a chemist. There are barriers, and in these barriers, we have barriers that are provider barriers. One is the negative attitudes towards young people. People always think, young people are complicated. So if they have that kind of attitude, then it will hinder them from providing services. They might not have the know-how on how to handle young people, or then they don't aware of any laws and policies regarding provision of AYSRH. The personal, religious, culture, attitude towards or beliefs towards provision of AYSRH is also another barrier. And then non-adherence to privacy and confidentiality, and unfriendly gatekeeper. Those are the people, they are very key. You might think that, they are not key. at the front end and the contact before the young person gets into the provider. Ability to have the hours that are the of opening, or young people come and wait for 2 years providing these services. There is no privacy completely. If they come again, commodity stock out is also another determinant factor, because if they come for the first time and did not get the commodity, they'll be discouraged to come again and restock the same commodity. The cost can also be prohibitive. Remember, the economic viability of the young people, very cost attached to a service. And then if you do not have any material or any poster when they are seated there, they get information, then it could be a barrier for a young to access services in that facility. But young people also have got their own barriers. And one of them are concerns about privacy and confidentiality. They always have this notion that, I'll go talk to a health provider, then the health provider will not keep the information confidential. They will share with other people. That is a barrier, because it's a mentality. It's most of the time it doesn't happen, but that is a barrier that also hinders them from us seeking these services, and we just need to continue engaging them. They might not be aware of various health issues. They might be facing one issue, but you Google today, if you Google Mr. Google, you tell, I have a headache, they can multiple reasons why you have a headache. So they might not have information on especially sexual reproductive health. We have talked about the prohibitive costs to cater for health services, and fear of being judged or humiliated when they are seeking services. They really fear, what will they think about me? Will they think that now that I've come for a contraceptive, I've started misbehaving and promiscuous? Or that is a barrier they have. Fear of knowing one's health status, especially for those ones who will come and they are told it is important for you to get to know your HIV status. They also have their own fear. And then they dislike very long queues and queuing, especially with other people, especially the older people. They do not want. The community also has its own barrier, and because community is a very key determinant whether young people can comfortably seek services in a certain facility. So there are community beliefs, attitudes, and misconception on access to services by young people. If the community is very friendly, facilitative, that encourages young people to, then they will, it will remove that barrier. Lack of community support on AYFS and lack of political goodwill. This affects mainly the public facilities, but I know even some private and even chemists. If an MCA, for example, is, not to a facility or has a bad perception, a certain facility, then it can bring some commotion, and that commotion can actually become a barrier to the uptake of services by adolescents. Next slide, please. So when you're talking about First, it has to be equitable. And in equity, we are talking about health services, discrimination in all their diversity. For example, a young person with disability. That is a person who also, they have their sexual reproductive health needs. And so we need to give services. Those living with HIV and those that are sexually active, we know in this cohort of adolescents and young people, there are others who are sexually active and others that, you know, they have not even started any sexual debut. Key population, we have young adolescents and
Naomi, we lost you.
this care worker should be non-judgmental.
Naomi, if you're speaking, you're on mute.
Gloria, I think I heard her drop off.
Yeah, I think she's still in the meeting.
I am around. So services are provided in a timely manner when a young person appears in a facility. We had already said that they fear long queues and they dislike being kept for too long before they get the service. Information materials are very appealing when the IC materials that a provider is displaying, it should be relatable to the young people. And adolescents should be meaningfully involved, especially in decision making on how the services are going to be provided to them. Again, we need to, should be accessible. And in accessibility, of course, we are talking about cost. So the costs should be friendly to the young people because they might not afford if we put very high cost. And then, of course, convenient hours for young people. If those ones who are coming probably after college, after university, they will come in the evening after, you know, past 5. Are they able to get the service at that time? So, and then convenient in where they are located, the chemist, for example, or a public facility is located. So are they accessible to young people? And then is the service appropriate? And when you're talking about appropriateness, the service package should be aligned to what is in the national guidelines on provision of adolescent and youth-friendly services. So health services should be provided in a way that make a positive contribution to the life of adolescents and young people. That is effectiveness, in other words. So healthcare workers should have the skills to provide the service. And so competency is very key. Competency in handling, even just talking, communicating to young people to open up so that they get the information and the service is very key. So services are based on available guidelines and protocols. So we should always ensure that we are there to the protocols that are provided by the national guidelines on provision of adolescent and young people friendly services. Next. So we have standards for quality in provision of adolescents, and there are 8 standards. So it's just outlining how the services should be, or for example, it's just scanning through. Standard number 1, the service delivery points provide health information to adolescents and young people. So the entry should always be information, not even the service, because the young person can only seek services once they have the information on the service that they require, and they will be able to seek the service. So standard 2, the service delivery point engages stakeholders, and in this, the parent is also a very key stakeholder. We have already mentioned the community, and in community, especially the community leaders or opinion leaders, on the value of providing health services for young people. Standard 3, the service delivery points provide appropriate package of health services to adolescents and young people. So it's not just one particular service, for example. It has to be, for example, a young person who is coming for contraceptive, for example. That is a young person who is sexually active, and they will, if they know their HIV status. Yeah, so HIV testing is also, it is to screen if they are undergoing any gender-based violence. So that is also another service. Standard 4, healthcare workers in a service delivery point have the competency. So they must have been trained on adolescent and young friendly services. Not really a training of 5 days or 7 days, but they must be oriented on, providing, so that they can give services that are non-judgmental. They can maintain confidentiality and the privacy when they are giving those services. And then pointing out is also another accessibility to the young people, and that speaks to standard 5 and services, irrespective of the ability to pay. We have young people who will come for the service and they're able to pay, and then there are others who will present, they are not able to pay, but you could clearly tell that they are in need. I mean, if you do not give that service, then something else will happen. So that speaks to standard number 6. And then in standard number 7, it is the service delivery points collect, analyze, and use the data on services utilization to continuously improve quality of service that you are giving. So service quality improvement is very key in standard number 7. And in standard number 8, the service delivery point meaningfully involve adolescents and youth in planning, monitoring, and evaluation. That means the young people, if you really want our services to be youth-friendly, we need to involve our young people. And we might not be able to call all young people in the community and involve them. We just need to get a representative, maybe someone who is vocal, maybe a youth champion, be part of decision making. And next. Slide, please. Just for provision of the that most of us are asking. Approach and targeted approach. These are services designed and planned only for adolescent group. And I know this is usually very difficult to hack, and because and there those ones that are able to alone, then that that model works perfectly. And then we have the adolescent services.
Hi, sorry, Naini. We keep losing you. It's a bit hard to connect the dots.
Now,
No, still breaking.
Glory, I'm still breaking.
Yes. We are hearing bits and pieces.
Oh, sorry about that. Maybe my internet is not stable.
Now it's a bit
And
better.
hotspot. So we have more. We have models for delivering of adolescent friendly. We have already mentioned that the two, we can use a youth-friendly center alone, or we can do integrated in our facilities. But in the bigger setting of model of delivering adolescent and youth-friendly services, it can be at clinic. It can be at the clinic. It can, the services can be provided in a clinic base. And when I mean a clinic, it can be a pharmacy, it can be a facility. And so services and information are, and then can also be taken to a community in a form of an outreach. So services and information are offered within the community setup. And a facility can, just the services that are being provided in a facility can be taken to a youth center, for example, in the community or a community space, those community social halls, as an outreach. And then it could be in a school-based model where services and information are offered within the school setting. And then the most common one is virtual-based model, where information is given to young people through the virtual space and or any digital platform. So it can be e-health, m-health, telemedicine, all those, or a hotline, or the chat box, for example, that we have just seen before this presentation. So all those are models for delivering young people, services to young people. So looking at the essential package for that's adolescent and young people, we had already seen vulnerability and the problems that the young people are facing. So that should be a basis on which services should we include in the package for AYFS. One of them is counseling. For you to provide contraceptive, for example, or anyone who is undergoing gender-based violence, the basis should be counseling. And so counseling should be one of the services that we need to plan to provide. So information also, it could be through IEC materials, it could be through acting, it could be life skills, mental health services. In counseling, we could also include not just counseling for SRH, but counseling for nutrition services screening, because our young people, as much as we are talking and focus on SRHR, but we know that they also have nutrition problems, for example, overweight or obesity, and to some extent malnutrition because eating habits, and regular menstrual period, all that should be. So counseling is part of the package. And then screening for services. So in screening, it could be cervical cancer screening, HPV screening and vaccination, comprehensive sexual gender-based services. We could offer pregnancy tests. We could offer contraceptive counseling and provision of services, the service itself, counseling and provision of contraceptive, and then the HIV counseling and testing, especially for 15 years and above, because they are able to give consent in terms of the HIV guidelines. So for reproductive and urinary tract infection testing and treatment, if of course there's such problems, sexually transmitted infection, screening, counseling, and treatment. For our male AYPs, we could offer voluntary medical male circumcision, adolescent, and so antenatal and post prevention of mother transmission. And when I put this package, it doesn't mean that all of us, all facilities qualify to provide these services. No. You can only just pick the level of, depending with the level of your facility. And for those services that you're not able to provide, then it's always important to refer to the higher, to the next level where they're able to get those services. So we all need to know or have at the back of our mind in setting up adolescent and youth-friendly services, what is the process or what is the procedure? And the first step, of course, we need to do a need assessment on the requirement for AYFS. And the need is informed by just the data that you collect. How many of young people seek services in your facility? How many staffs do you have? You know, the infrastructure, are you able to provide services for young people, for example, where you need privacy? Do you have a separate room, or are you able to partition that room so that there's privacy? Once you've done a need assessment, then you build the capacity of the healthcare provider. And when you're talking about a pharmacy, for example, maybe you have 2 or 3 staffs. So this could be simple OJT. It doesn't have to be a 5 days training or a mentorship, one to be trained and to mentor the rest. And then you need to establish adolescent and youth-friendly infrastructure. For example, when a young person is passing, just across, near your facility, is there signage that shows that this is able to provide youth-friendly services? How is the ambience? What are your operating time? It needs to be captured so that even if they were not seeking services at that particular time, while they are passing, they have at the back of their mind, if they need that service, they will always remember, oh, I've seen a facility that, I can get these services from. From there, you need to establish program to sensitize adolescents. And we said for a facility, you will not sensitize all adolescents. You just need a few representatives that can act as agents to reach out to other young people at the community. And so you can bring on board them and then get some IC material where they can spread to the rest of the young people. And then from there, it could be health talks at the facility or community, all that. And then you need to establish a program to sensitize the community as well. We said the community is very key because they also have to be onboarded so that they can be able to refer young people. Then meaningfully engage adolescent and youth in provision of the services. So still use a smaller group of young people to reach out to the rest of the young people. Provide appropriate package of services, especially the services that we have mentioned in the earlier slide. Ensure that at least you layer your services, not just one contraceptive alone. And then from there, ensure availability of data capture. Once you have that data, it will always enable you to make decisions, help you improve your services, and and be able to continuously provide quality service to the young people. So I think that is the end of this presentation. Back to you, Gloria, for any question. Thank you.
Thank you, Naomi, for the amazing session. We have some brief questions. I can see Paul has answered some. Naomi, maybe you can take this one in case there are any other questions. We'll take maybe 1 minute to take that. A parent approaches you to talk to their adolescent child who was discovered in possession of pornographic material. What kind of advice can I give? That is the question. Naomi?
Thank you. The child was discovered with pornographic materials. So they're looking for advice to give to the child. So I think the starting line is, of course, to talk to the child first. Get to know how much they know. Of course, a pornographic material is already very extensive. And I don't know whether I have mentioned that curiosity is also one of the things that lead young people to such curiosity. And because most of the parents, or most of the parents, where these young people are supposed to get information from before they get it from friends, I will not say they do not give information, but maybe they lack capacity on how to do age-appropriate information. And so for me, I think the first is to sit down the child and get to know, depending with the age of the child, get to know what they already know about sexual conversation, and then you build from there. Once you build from there, of course, you always want to start with the positive before you go to the negative, because what is negative will always stick to their mind, and it might work against the child and even the parent. So we start with the positive, get to know, give age-appropriate information, and then from there now, we go now to the negative effect of engaging in sexual, because if they watch, they might be curious to also engage. So negative, and then from there now, we continuously talk to the child, walk through the journey, because this is a child that wacha nisema ameenda sana pornographic, it's excessive, but all is not lost. Start from the positive, and then again, let's talk about the negative as well. Thank you.
Thank you, Naomi. Thank you, everyone, for taking time to join the sessions. Hopefully this training will be impactful to you and the work that you are doing. If you do share the same on social media, we have some of the hashtags to use and maybe why we use them in regards to the same. Bridget, maybe you can show the next slide. When we are engaging on social media, our primary hashtags are hashtag advanced FP in pharmacy and hashtag FP in pharmacy. And of course, the secondary one is hashtag family planning, hashtag DMPSC because of self-care, hashtag contraceptive Thursday, hashtag reproductive health. If you do use any of the medias, any of the materials we've shared and everything, always tag inSupply Health. And of course, the professional associations, both KP and PSK, either on Facebook, be it Twitter and LinkedIn. And you're probably wondering, why do we monitor the hashtag advanced FP in pharmacy? Because at the end of the day, we want to strengthen advocacy and messaging, and we want to demonstrate momentum and demand for FP services, especially in your pharmacies. And of course, we would love to measure the reach and engagement of FP in pharmacy content. That is why these are important. Sorry for going over time and taking 11 of your minutes. I hope all of your questions have been answered. And in case of any follow-up questions, I know most of you are in the groups. Please feel free to ask the questions. I have shared a link in the chat. Please use it to give feedback on what did you think about the session. Was it a learning experience for you? Have you picked things that you could employ to ensure you get young people clients and that you retain them in the long run because they trust you and the services you deliver? Paul has also shared the link to the Sema na Mi chatbot. Please feel free to engage with it and use it to test how viable it is. Please use it. And in case of any questions, we will be here. We'll be able to answer them. Paul, is there anything you want to say about the Sema na Mi chatbot in terms of onboarding them? And then we can close off.
No. I think just click on it, WhatsApp, just go around and just see what's on there. And yeah, you can use it and just see how the kind of advice and the kinds of conversation it's having. There's no special thing in terms of onboarding. You'll just get a few questions in terms of just to get your details, but very, very, very conversational and very short.
Okay. Thank you so much, Paul. Any last words from Bridget and Naini?
No, just to say thanks for the opportunity and thanks to everyone for listening and for your feedback.
Thank you so much, Naini. Okay. Thank you so much, everyone, for taking the time to join today's presentation. We are wishing you well out there. Please implement what you have learned today, and we'll continue conversing on how to improve youth-friendly services in the pharmacy. Thank you, and have a great night, everyone.